Okay, good evening, everyone, and thank you for joining us tonight. We really appreciate you taking the time to be here with us. My name is Dr. Alex Puidapa. I'm joined with my colleague tonight, Dr. Charles Nwanzi. We're excited to speak with the El Paso community about benign prostatic hyperplasia, or BPH, and a potential minimally invasive treatment option called prostate artery embolization, or PAE. So tonight we'll discuss BPH, some of the symptoms associated with it, treatment options available, uh, how PAE may help men improve their urinary symptoms related to BPH and their quality of life without traditional surgical techniques. We're passionate about bringing advanced patient-focused care to our communities, and we're looking forward for an informative discussion tonight. And we'll be happy to answer any questions you may have at the end. And we have some questions that we are commonly asked by patients. So without further ado, we'll get started here. So we are IR centers or prostate centers. We also heavily involved in the GI space and ortho space. As I mentioned, my name is Dr. Alex Puidapa. Charles Nwanzi is also an interventional radiologist. So we're both interventional radiologists, which means we specialize in minimally invasive procedures or techniques where you use image guidance to implement some type of diagnosis or therapy. And in today's talk, we're talking about PAE, or prostate artery embolization, which is a minimally invasive procedure for BPH. So understanding BPH, or benign prostatic hyperplasia, um, I think if you're on this call, you probably have BPH, or you know someone who does. But what it means is um, your prostate enlarges over time. And as the prostate enlarges or grows, it can make it harder to urinate because the urethra, which drains the urine from the bladder, passes through the prostate. And that prostate can constrict that passageway, and it can even grow up and into the bladder. And it's a very common and very treatable condition. Up to 15 million men in the United States are affected by BPH. Most men in their lifetime will develop some degree of prostatic enlargement as they age. A quick and dirty number you can remember is 50% of the men at 50 will have BPH, and over 80% at the age of 80 will have BPH. Or enlarged prostate BPH with symptoms. What are some common symptoms that you may experience with BPH? Frequent urination, or an urgent need to urinate, meaning when you gotta go, you gotta go. You could be at like a sporting event, and all of a sudden you gotta go and you gotta rush to the bathroom. Weak or slow urine stream, which is pretty common, where there's dribbling or difficulty initiating, or it just doesn't flow the same way it used to. Waking up at night to urinate. And this is probably one that's underestimated and really impacts quality of life because if you're waking up one, two, three, some men wake up four, five, six times a night, it really impacts your quality of sleep and energy levels the next day. So while it may sound not too bad, you're like, oh, I get up a couple times a night, but it really impacts the rest of your day and your overall energy levels. And then other symptoms may be not emptying your bladder completely, not feeling like you're emptying your bladder completely. Um, so as I mentioned, the prostate sits just beneath the bladder, surrounding the urethra. When it grows, it kind of squeezes that channel or that tube. Men often describe it, as I mentioned earlier. I can't hold it when I have to go, getting up two, three times a night to urinate, weak dribbling stream, feeling like I'm never emptying my bladder. Um, Other contributing factors. So will it get worse? BPH is not prostate cancer. And just because you have BPH doesn't mean that you're predisposed or at higher risk for prostate cancer. However, it is a progressive condition, meaning your prostate will continue to grow without treatment over time. Um, Caveat to that is you can have prostate cancer and have superimposed BPH, but BPH doesn't necessarily lead to prostate cancer. Um, so prostate size comparison. Some of you on the call tonight may have already had your prostate sized. I like to put this diagram up just to give people a context because they usually give it to you in cc's, grams, or mLs. Those can kind of be interchangeable when you're talking about volumes like this. But a normal prostate is about the size of a walnut, or about 20 to 30 grams. And then as you go up in size, 30, 35 grams is your ping pong ball. A golf ball is about 40 grams. When you're getting into the fruit or the clementine, that's about 60 to 70 grams. And then you get into a tennis ball, you're about 150. You go to like 200, it's about a grapefruit. Um, so that's kind of just to give you a ballpark in the size. But to be honest with you, you could have a patient with a 30, 35 gram prostate and have more symptoms than a patient who has a 60 or 70 gram prostate, because a lot of it has to do with the shape of the prostate and actually how it grows and how it constricts. So it's not necessarily, oh, my prostate's 60 grams, so it's worse than a patient who's 30 grams, or my prostate's 30 grams, so I don't have to worry, but your symptoms are actually really bad. Um, it's more just to give a gauge on what treatment options would be available to the patient. That segues in or dovetails into what the treatment options are. So, in deciding what treatment you're going to go for your enlarged prostate, um, you really should be informed and know what options are out there. And I think you guys are lucky with Rio Grande Urology, in this area, that you have practices that offer a plethora, or basically pretty much all the treatment options. So how are the BPH treatment options? How do they compare? So most patients will be started on medications, um, something like finasteride or tamsulosin. These are medications that can be taken long term, but they don't necessarily shrink the prostate, and side effects are common. So some of the side effects can be like dizziness, low blood pressure. With finasteride, it can be reduce libido. You can have retrograde ejaculation with some of these medications. So they're not without necessarily harm. And then you move up one level, and then you have the minimally invasive procedures. So I have a slide coming up that kind of has cartoon pictorials of some of the other treatments, but there's Urolift, there's Rezūm, there's prostate artery embolization, which we consider a minimally invasive procedure. Um, there's other procedures where we call resective or surgical, whether it's TURP or transurethral resection of the prostate. There's different iterations of resective procedures, like aquablation, where they use a high-powered heat-free water jet to resect the prostate tissue. And then there's HoLEP or holmium laser that helps carve out prostate as well. And then, as I mentioned, PAE. It's probably the least invasive of all these treatment options, which we'll go into obviously in more detail. So here you have that Urolift, which this is the cartoon that's showing. Basically, they go up the urethra and they mechanically open up that channel using basically like suture or staple type like material to open that channel. Um, you'd qualify for this procedure if you have like a smaller gland, usually maybe 80 or less, without a real prominent median lobe, which that's what I was talking about with shape of the prostate, which a median lobe is a portion of the prostate that not all men will have, but a central portion that will grow up into the bladder. Prostate artery embolization, which we will go into in further detail later, Rezūm, and aquablation. So these are some cartoons. So here's a cartoon of in the top left, that's going to be your Urolift. Um, in the top right, that is going to be your Rezūm, where they use basically like steam to enucleate or shrink the prostate. Um, uh, that's using that steam or water vapor there to enucleate the prostate. And then the bottom two are the same procedure. This is that aquablation, where basically they carve out or power jet out prostatic tissue. It does a great job at increasing the flow, and really opening that channel. Um, so, um, what you should know about PAE. So PAE, as I mentioned, is probably the least invasive. Is a very low risk profile and very low side effect profile. The way it's performed, at least in our practice, with IR centers, is it's a day procedure. So you come to the office and go home the same day. Um, The procedure itself usually takes about 30 to 90 minutes. All in all, you're with us for about 3 to 4 hours. You usually get there about an hour before. As you mentioned, we'll say about 30 to 90 minutes. So we'll say about an hour. And then recovery is usually somewhere between 1 to 2 hours. And that's really just to let some of the sedation wear off because we do this under what's called moderate sedation. So it's like a twilight sleep. Success rates with PAE, meaning when we perform the procedure, we expect 90% or greater patients will have improvement in symptoms, and there's no hospital stay. You're not staying in the hospital, as I mentioned. You go home the same day. Could PAE be right for me? So the first thing that would be important would be if being evaluated. So knowing that you do have BPH, there's a questionnaire or an IPSS that helps gauge how severe your symptoms are. It could be that you already know you have BPH and you're on medications like Flomax or tamsulosin or finasteride, and they haven't adequately um, helped with your symptoms, or they have unwanted side effects, like some of the ones I mentioned. Um, your symptoms are still severe. Here's a key one that's important to a lot of men. Um, you're you want to preserve sexual function. So with PAE, there is no risk for incontinence. There's no risk for erectile dysfunction. There's no significant ejaculatory dysfunction. Some men may experience transient hematospermia or blood in the semen for a few days to a couple of weeks, which would resolve on its own. Some men may also experience a slight reduction in volume in semen for a short period of time, which also would return on its own without necessarily doing anything else. Whereas some of these other procedures do carry that risk where you can have impairment of sexual function or ejaculation. Um, you may be a patient who just prefers to avoid surgery. You want the minimally invasive alternative that's you know cutting edge, and that may be you. And PAE may be what fits your goals there. Um, so how does prostate artery embolization work? So what are we doing in the actual procedure? So basically, as I mentioned, it's done under moderate sedation. So what will happen is you'll change into a gown. We'd start an IV. We'll administer some medicine through that IV, and you'll be in a nice twilight sleep. Over you, we're going to basically use an X-ray camera, and be using live X-ray, which will help us basically use the blood vessels as a road or a highway to get to the blood vessels that supply the prostate. So through a tiny pinhole, we'll access the blood vessel either in the wrist or the groin. We typically will go through the groin because it's a shorter distance and there's definitely a safety profile that's a little bit more attractive from that area. And then we'll use this tiny little thin catheter or flexible tube to go to the prostate. Once we're there, we will slow down the blood flow or block the majority of the blood flow, that's what embolization is, by using these tiny little microspheres made of this biocompatible material. And then usually we'll pack that in with a foam-like material called gel foam. When we're done, we take the catheter out. We usually close the tiny hole that we use to get into the blood vessel. And then you go back to the holding area where you recover, as I mentioned, for about 1 to 2 hours. So here we'll hop on the magic school bus here, and this is kind of a cartoon of that. So we'll bypass the bladder here. That's what that top tannish structure is. And then we'll take that microcatheter and strictly target the prostate. And it doesn't shrink like this in real time. It actually takes a little bit of time for that to happen, but that's the idea. You can see a cadaver image of what that kind of looks like, the before and after. Here is actually what we see in the procedure. So these are the actual images from a procedure where we basically can see um, all the blood vessels in the pelvis. So, but what we do is we kind of put the X-ray machine in a projection that will open up these pelvic vasculature and select the blood vessels that go to the prostate. This is sped up a little bit, so Chuck's fast, but I don't know if he's that fast. But this is what you see here. So this is that enlarged hypervascular prostate, and this is where we would deliver those beads and be very selective on where we administer those. Let's see. So your recovery after PAE and what to expect. So the day of the procedure, after it's done, you might have some mild soreness at the access site. Like I said, we make a tiny, tiny little incision. There's no like sutures of the skin or stitches at the skin. It's really just you leave with a Band-Aid. We'd say you take it easy for that day, hydrate well. We do recommend that you have a driver. You cannot drive yourself that day because of the sedation medication. For the first week, I really say about, or we usually say about 5 days, no heavy lifting, no strenuous activity. Um, 5 days is usually enough. We'll follow up with you usually on the next day. Just make sure you're doing okay and you're recovering well. You can shower the next day. No submerging like pool, jacuzzi, hot tub for a week because we just want that tiny little nick that we made to get into the skin to heal up properly. And second or 2 to 3 weeks, you'll start to notice improvement. And then at 3 months, we like you to follow with your urologist because that's where you'll see your maximal benefit from this procedure. And what results or that segues into the outcomes. Um, what results should you expect? So, as I mentioned, 90% of patients are going to see symptomatic improvement. Um, and what that means is greater than a 50% reduction in their IPSS score. The durability or how long this lasts. So any of these procedures you do, basically short of total prostatectomy, will have some degree of recurrence over some period of time. This has about a moderate degree of durability, meaning it lasts about 5 to 7 years before patients may experience some return in symptoms. This procedure can be repeated. It doesn't preclude patients from any other procedures in the future. So the ones that will last longer are the resective procedures typically. So that's your TURP, your aquablation, your HoLEP. So those typically last longer. Obviously, there's a trade-off. There's a little bit more risk and side effects with that. So this is a nice middle ground that can be repeated. And sometimes it's used as an adjunct with some of those other resective procedures as well. Um, uh, as I said, most men will experience significant reduction in urinary symptoms. It's greater than 50% reduction in IPSS. It's usually about somewhere around 11 to 14 points. Um, Prostate size will shrink somewhere between 20 and 40 percent overall at that 3 month mark. And we don't necessarily follow based on prostate size, because I mentioned before, size isn't necessarily a determining factor. It's more symptomatic follow-up that we will have. Um, Results vary, obviously. Larger prostates may have, and more severe symptoms tend to respond very well. Sometimes smaller prostates may not have the same amount because if you're shrinking about 40% of a really small prostate, it may not necessarily um, respond the same way. But in our experience, even smaller glands, if you have irritative symptoms, in particular frequency, urgency, waking up at night, they actually still do really well with this procedures. Um, So we talked about these already. So different urinary oral medications and then certain lifestyle habit things. The biggest one lifestyle wise would be avoiding like fluids right before bedtime, irritants to the bladder like spicy foods and carbonated beverages. Those are really the biggest things when you're talking about like lifestyle changes. Caffeine, alcohol also can play a role or have an impact. Now, we're not going to say don't do any of those things. We want you to live your life, but if you're cognizant of those things, it can be helpful, and you can be mindful of what is actually contributing to some of your symptoms. um, Insurance and what to expect. So thankfully, we've done a lot of work advocating for PAE, and a lot of people on our team help write some of the guidelines for a lot of the payers. So PAE is covered by Medicare and a lot of the commercial insurance plans, more and more each day. Um, so it typically is covered. I would say I would encourage you to set up a consult to see, and once you do, and we have a team that will look up your insurance and kind of do all the heavy lifting on the back end, so you would know what, if anything, you would owe prior to coming in for the procedure. Um, some insurance or payers would require prior authorization. We will take care of all of that. So maybe, Dr. Mwanze, you can kind of take some of these questions. These are some of the common questions that we get asked. We addressed some of them on in the talk, but maybe now, Chuck, you can kind of chime in on some of these. And I don't know what when a patient asks you, "Is the procedure painful?" What do you typically tell patients?
So it's the most patients, the vast majority of patients don't have any pain with the procedure. We do it under light to moderate sedation. So what most people feel is that initial bee sting. I tell you, I usually tell folks it's like a bee in the lower valley. Just stalk you for a second. It stings for a minute and then it goes numb. And that's the local anesthetic basically numbing the area. And once that area is numb with ultrasound and X-ray, we get that microcatheter into the blood vessel. And for the rest of the procedure, you just lay down on the table, and if you fall asleep, that's okay. But you're just kind of in a twilight zone, so it's not a painful procedure.
How
Just
about how about when patients ask you, "Will I be able to stop my prostate medications?" What do you tell them there?
So I usually tell them that I would let for the first 3 to 6 months I would actually want them to continue the medicines and because this is the duration of the time that the prostate is going to get its maximal shrinkage. Then at about that 3, 4, 6 month mark, we'll have an open conversation in concert with your urologist, and you will tell me if you say, "Hey, I feel like my stream is good enough that I think I can go off my alpha blocker."
Mhm.
And if if the procedure works well for you, and you are in concert with your urologist, you feel like this is a good time to stop the medicine. Then at about that 3, 4, 6 month mark, absolutely you can come off the
Yeah.
medicine.
And I would add to that, I would say actually most men, it's yeah, around usually that 3 month mark, are able to come off the meds completely. I'd say probably over 80% of the men are off meds completely.
Mhm.
How about when you're talking to patients? What do you talk about when you talk about? We talked about prostate artery embolization being lowest side effect profile, lowest risk profile. But what risks do you mention to patients when you're talking to patients about PAE?
So, in terms of the risks, I always specify that this is a very safe procedure relative to the other minimally invasive techniques for dealing with prostate embolization or the surgical techniques. It's very safe. You have some mind like, with any procedure. Anytime you go through the skin, you run the risk of infection, bleeding, damage to the nearby organs. We don't see infections. We because the procedure is going to be done in a completely sterile manner. Bleeding, no. While it's a risk that we have to be cognizant of, this is not something that we see. These are minor access site risks. There is a risk of some urinary symptoms, like some people may notice some blood in their urine. These are usually self-limited, usually not running more than 3, 4 days. If it does happen, there might be some burning when you urinate, what we call dysuria. There might be some mild pelvic discomfort. Many people may complain about an increased frequency of urine, particularly for those first 3 to 5 to 7 days after the procedure. I always tell people that maybe you might hate me before you like me, because in that first week you are going way more frequently to the bathroom. You are waking up at night a little more frequently to urinate. But by the second week, you start noticing improvement in the symptoms. There are some rare risks, like what we call non-target embolization, where there might be some discoloration of the skin of the scrotum or the penis. These are rare, but they can potentially happen. And we always like for, and if they do happen, they are self-limited. If there's some what we call penile necrosis, it may take a little longer, about 3-4 weeks to heal. But these are not these are all self-limited complications in their own rights.
Yeah, and I think you covered some of these other ones. How long it will last? Let's see. I think I have another page of questions. We talked about insurance. Um, how about what should patients do to prepare for the procedure? What do you usually tell them?
So yeah, I always try to emphasize that no breakfast on the morning of the procedure. We tend to we prefer to schedule our procedures for the morning. So that means we get you in early in the morning. As Dr. Pavitapa mentioned, it's a same day outpatient procedure. So we get you in early in the morning with an aim to get you out by late morning or early afternoon, depending on what time of the morning we start. So no breakfast, just plan for a late breakfast after the procedure or an early lunch.
Hmm.
I
Hmm.
always want you to come with someone who can drive you after the procedure. And the reason for these two instructions is because of the sedation. We wouldn't want you to have nausea or vomit while you are lying flat on the table. And if you have a full stomach, that can that can be risky in and of itself,
Hmm.
particularly when you're sedated. And in terms of the driving, yes, you are walking, talking after the procedure, but you technically will not be legal to operate heavy machinery like a motor vehicle for that day of the procedure. So we'll like you to arrange for a designated driver who can take you along. In terms of medications to stop, I usually take it on a case by case basis. Most people who are on routine blood thinning medicines, I might have you hold the blood thinning medications. But if for whatever reason there's a reason I cannot stop the blood thinning medications, that's not a it's not a major, should I say, major contraindication for me not to do the procedure. Um, and our nurses do an awesome job of calling you a few days before the procedure to go over the checklist of what you need to do and bring prior, particularly picking up the anti-inflammatory medicines that we would like you to take. The post-procedural medications, we want you to fill them out before the procedure so that you are good to go as soon as the procedure is done to get those taken.
Yeah, and I think one thing as we wrap up, I think there's one thing that I would like to add is that um, this procedure is awesome for patients because it's minimally invasive, low risk, same day procedure. You don't go through the penis to perform the procedure. But I think one component of it that should be considered is that who you choose to do your procedure because Chuck, you and I both know this is a challenging procedure, and you
It
want someone
is.
who's done this hundreds of times. And you guys are lucky to have Dr. Nwanzi, who's done hundreds of these procedures. So I think if you're interested in PAE, you should definitely ask the doctor, whoever. If it's going to be Dr. Nwanzi, that's great. But even if you decide to go somewhere else, I think it's fair to ask how many of them they've done because it is a challenging procedure to do, but in the right hands, it gets done the proper way. Um, I don't know. Is there anything else you'd like to add? I think, I appreciate everybody's time. Encourage anyone to reach out and set up for a consult if this is something that you're interested in. Here's some contact information here. But yeah, I would leave the floor to you, Chuck, if there's anything else you want to add.
And no, that's it. We are open. We're in downtown El Paso, Central El Paso. The address is there, 2211 East Missouri Avenue. And we are here to, this is way more common in the community than you can imagine. And we are here to make a difference for you.
All right. Well, thank you everyone for taking time out of your evening. And look forward to hopefully meeting some of you in person at some point.
Thank you.